That's what they're all saying. We're still trying to figure this out. But that doesn't mean that organizations can't be preparing for these funds so that the minute that these grant opportunities come out, they are prepared to apply for them. So that's why I said, like, look at your patient population now. What problem can you solve? What baseline data can you pull? Be prepared. Don't wait for them to come out. Do the work now.
Try to fix the current system or reimagine something new. Will healthcare ever serve consumers just like me and you? The power's in our hands, but every side's gotta come together. We want the newer generations to get something better. Until we flip the script and talk about what gets prevented. Until we see the changes permanent as if we meant it. Until healthcare is finally consumer-centered. We've got a lot to rap about.
Welcome back to the leading podcast about how consumer health works. We spotlight how healthcare is being designed, marketed, and delivered from the consumer point of view, and profile leaders who are championing the move to preventive care. If you want to understand healthcare both as a builder or operator and as a consumer yourself, this is the place for you. Here's what's going down today. First up, we have the Flava of the week about Cityblock's rumored acquisition of Homeward Health. How are the two primary care startups reportedly considering joining forces, and how can building within existing payment models lead to expanding access to those who need it the most? I'll talk about that. Then Carrie Foote breaks down the Rural Health Transformation Program in plain English and shares how rural health clinics should be thinking about partnerships with hospitals, tech vendors, and state agencies. I'm Jared Johnson. Let's get it. A rumored acquisition could expand access to consumer-centric care among low-income seniors. According to Endpoint's News, Cityblock Health is in talks to acquire fellow General Catalyst-backed primary care startup Homeward Health. The article quotes an anonymous source and says the proposed acquisition combines two health tech startups providing primary care services, as well as support for non-medical factors that affect health outcomes, such as getting access to food, transportation, and housing. Cityblock works with lower-income patients on Medicaid and Medicare plans, while Homeward services patients in rural areas, mostly on Medicare Advantage. The combination would help Cityblock further expand in Medicare. What's the consumer lens? For consumers, the biggest benefit could be a more connected healthcare experience across different stages of life. Together, the combined organizations could bring coordinated primary care, behavioral health, home-based services, virtual care, and care navigation to a much broader population, particularly those who have historically struggled to consistently access healthcare. Rather than losing care coordination when transitioning from Medicaid to Medicare, patients could remain within the same care ecosystem, reducing the need to change providers or repeat their medical history. Rural communities in particular would stand to benefit from expanded telehealth, home visits, and chronic disease management, while the company's value-based care model emphasizes preventive outreach and addresses social needs before health issues become emergencies. If executed well, the merger could make healthcare more proactive, coordinated, and accessible for many of the nation's highest need patients. And while some may question the need that General Catalyst could be playing in the deal, I see little downside to expanding models of care that, for the most part, seem to be working when patients and families need it the most. Let's consider how building within the existing payment models of Medicaid and Medicare can be what brings more consumer-centric care to those who need it the most. That's another way that we'll build the healthcare of tomorrow, and that's the Flava of the week. All right, everyone, let's get into the flow. My guest this week is Carrie Foote. She's the founder and principal consultant of Forward Health Strategies. We're going to dive into topics that are really in vogue right now, as well as being able to leverage a lot of the experience that Carrie's had in this space. We're talking rural health, we're talking RHTP, we're also just talking more broadly about not only the rural health landscape, but how that has to come into play with, I think, a lot of other trends that we've been talking about lately. And the bonus is that she is also based here locally in Arizona. So very excited. Carrie, welcome to the show.
Thank you so much for having me today. Happy to be here.
I hope I introduced you correctly there. Do you want to give us just, a minute or two about your background? Like, what would you like our listeners to know about you?
Sure. Yes, that was the perfect introduction. So I've been in healthcare since 2004. I started in community mental health and addiction services locally here in Tucson, Arizona. I started as a case manager, what I very affectionately call being in the trenches and working mostly with a Medicaid population. And this is where I started to see the friction point between the healthcare being accessible, but not exactly what our consumers needed from us. And then also friction points between administration and direct care providers. Sometimes administration will make decisions that impact how we can deliver care to our members, and then our members become disgruntled. And I'm a person who believes in being a part of the solution. You have to be the change that you want to see in the world. So I left the direct clinical care and went over to the administrative side and really kind of ended my career as a chief operating officer and a chief compliance officer. I really love having my feet in both boats of operations and compliance. And today, under Footforward Health Strategies, I remain as a fractional compliance officer for a mental health provider here in Arizona.
Fantastic.
I've done a lot of work in the rural space. I was a part of an organization. We did an acquisition and started providing services in rural southern Arizona. That was my introduction to rural health. And one thing that I like to say is rural people who live in rural America, your geography should not define your health outcomes, but we know that it does. Therefore, this is why I have such a passion for working in rural United States, not just in Arizona. I am state agnostic at this point and work tirelessly to really make that healthcare accessible and building it in a way that empowers clinical teams and empowers patients, the consumer.
Yeah, thank you about that because that's clearly like a core belief that you have, like
Yes.
your philosophy about care, about your geography not defining it. But we know, I mean, I love the realistic aspect of that. We know that it does. We know that your geography does define what care is able to be provided. It's interesting thinking about that in the environment that we have today. I think it can be easy. Maybe I'm alone in this, but it can be easy in the industry. The more we've heard about telehealth for the better part of a more than a decade now, we've known that capabilities exist. We knew that things like virtual care became more available and got implemented a lot during COVID and immediately, right after COVID, right after the pandemic at the very least. But yeah, we have all these capabilities, and it could just be easy to think or assume, okay, everyone who needs to implement certain tools or strategies has done it, and that's far from the case. What else about your journey and the work you do is useful for our audience to know, especially in like you said, we can talk about Arizona, but we can broaden that out to other, to state by state. What else, I guess, what else are you seeing there, and what else has come across your desk, so to say, as you've been working in this space?
Yeah, absolutely. So I think you hit the nail on the head with COVID. It spun up virtual care services really rapidly and quickly. And so I'm really seeing two things. One, I am seeing people who spun up virtual healthcare services, telehealth, during COVID so that they could reach their patient population effectively and safely, but they implemented it really quickly. So at this point, they are beginning to realize that what they built is no longer working for them. So I come in and I help optimize existing telehealth programs. So that looks like we're looking at staffing patterns, we're looking at the technical tools that they're using, we're looking at the patient care journey, we're looking at how clinicians and the care team they're satisfactory around the virtual healthcare tools that they purchased and they implemented, and really working with them to fix the bugs in their systems. The other thing that I'm seeing, there are a lot of federally qualified health centers, rural health clinics, critical access hospitals that did not have the opportunity really to spin up virtual healthcare services because they didn't have the money or the infrastructure or the internal expertise to be able to do so. And they are understanding and really realize and appreciate that without being able to offer these services, they are not going to be able to compete in their communities and in the market. And so I have worked all the way from West Virginia to Washington State to help them build telehealth programs, remote patient monitoring, chronic care management programs. So that's what I'm seeing. It's a pretty even split between we need to implement it versus we really need to optimize and improve what we're doing because it's not working well for us right now.
Yes, thank you. And I think the broader context of that for me is how that connects to what we've been experiencing and all learning about in such a rush. I feel like it's similar to the way that a lot of healthcare organizations just all of a sudden kind of flipped a switch during the pandemic and said, let's learn about and figure out and implement telehealth. In a similar way, I feel that same kind of like time sensitiveness about the rural health transformation program, which coming close to finishing the first year of it being a thing in existence. There's a lot. So, some days it floods my LinkedIn feed, for instance, and I'm trying to, get a better handle on just the main parts of it. So I'm curious what you're seeing here. Like, what are the media and other industry sources generally getting correct when it comes to it? We'll just refer to it as the RHTP. as they're reporting about it? What are they getting right in general? What are they getting wrong?
Yeah, I like to just kind of start with a general overview to make sure that everybody really truly understands what the Rural Health Transformation Program was funded to do. So it's the $50 billion. It's the 5-year federal initiative designed to transform rural health care delivery. It is not meant to be short-term relief. This really is truly meant to transform the way that healthcare is delivered and consumed in rural America. $10 billion available each year over the course of 5 years. And it's more about building really sustainable systems and not really just patching existing financial problems, which we know absolutely exist for our rural providers right now. So I think what media is getting right, Jared, is that technology really is central to this program. CMS very strategically called out technology that they expect rural providers and people who are recipients of this funding to implement. And that can be things like telehealth. It is things around remote patient monitoring, data sharing, the interoperability of patient health data so that somebody doesn't need to go repeat an MRI 3 times. A provider can pull down the most current MRI that they've had and actually use that to inform the care delivery that they're going to be providing. It's also things around cybersecurity, which we know in rural America, they don't typically have the infrastructure, the expertise, or again, the funds to be able to have really robust cybersecurity programs. And that is absolutely impacting our providers and patients alike. So those are a couple of examples of the technology. What they also are correctly connecting is that RHTP is designed to help somewhat offset the Medicaid funding challenge and hospital sustainability issue. Very shortly here, we are having millions of dollars cut to our Medicaid program, and that is going to directly impact our rural healthcare providers. So, just to give a couple of statistics here is that the Kaiser Family Foundation, they estimated that the fund could offset about 37% of the projected $137 billion reduction in federal Medicaid spending in rural areas. And then our great partners, the National Rural Health Association, also rightly framed the RHTP funding as one piece of a longer-term sustainability strategy, not a full replacement of lost funding. So really that's what I'm seeing, that it's really designed to use technology to help close the gaps on things, and that only part of this funding will be used to offset the billions that we are losing in our Medicaid program.
Awesome. So technology is clearly a big part of it. What else, is associated with when we're talking about like the grants that are being awarded state by state? What else is in there that maybe we just don't hear as much about? Or because I understand that probably that's the main thing I hear a lot about, but then I'm also seeing and hearing opportunities to connect communities, right? Like if as a rural health clinic or an FQHC, is implementing something that they've gotten awarded through this program, they still then need to connect their community and like let people know about it. Like do some outreach about that. Is that included, or what else could be included? I guess.
When you started talking about connecting with the community, I immediately started thinking about partnerships that grantees or people who are applying for these grants should really be considering. Who are your community partners that can help get the word out about a new program that you're starting and that you're implementing? And those are things that you should think about from the very start when you're thinking about applying for these funds. And if we want to dive into some practical advice for people who are going to be applying for these funds, I have a bunch of it.
Yeah, let's do that.
I have a lot of strategic practical advice. So here is the first one. Know what your state promised CMS they were going to achieve. Please go look at your state's plan and read exactly what they promised CMS they were going to improve and change. Because if the state cannot demonstrate that to CMS, CMS is going to claw back that state's funding. What's going to hurt even more for a state is that there is another state that is performing really well. They're going to give your dollars to that other state. That would be a big rub, I would think, for a state. Not only did we lose it, but we also had to give it to another state. So that's the first one. The second one, now that you know what your state was trying to improve, Is that something that your organization can actually approve in your community with your patient population? Do you have the infrastructure that you need? Do you have baseline data that you can pull to say, hey, look, this is where we are today. We are going to go apply for this funding, and this is exactly how we're going to improve the patient health outcomes in our community, which will then help our state move the needle and demonstrate to CMS that the funding that they gave to us was used for the betterment of our communities throughout the state. And thinking about those partnerships, if you don't have everything that you need to move the needle, who is a natural partner? Don't try and force the partnerships. Really look for people who are well aligned with your mission, your vision, your objectives, your patient population, and write them into the grant with you. They could even be a sub-awardee of the grant that you're going to be receiving. I think the other thing to your point about some technical assistance for these organizations, if they don't have the internal expertise, write into your grant, find a consultant or consulting firm who can help you implement the program that you're trying to design. You really need to do an internal inventory to see if you have the expertise that is needed to really fully implement and sustain the program and produce those measurable outcomes that you can prove.
So is part of the complexity here just because it varies so much by state, that we can't just blanket say like here is the generic, guidance about things like partnerships, like does it vary a lot by state, I guess?
It does. Every single state wrote a different application. Every single state's application brought in things like technology and workforce development, access to specialty cares, a hub and spoke model. But each one of them focused a little bit differently on each one of these topics. They have different measurements that they promise to CMS. Some of the measurements that we saw in some of the states' applications look more like inputs and outputs versus really reducing things like ED visits, hospitalizations, A1Cs, blood pressure. For me, when I am looking to transform rural healthcare, that's really what I am looking for in an organization. Are you trying to improve your population health versus, hey, we started a telemedicine program and we had 152 visits last year? Like, okay, but what did those 152 visits last year actually produce for your patient population?
Yeah. Okay. So I would guess most organizations have a foundation, at least of to that point of being able to capture some data, some results. And so you're saying like connecting that, taking it further, and understanding like how the grants are being determined. And to your point, I mean the part about like CMS could grant some of those funds back to another state at some point.
Yes.
Like that's sobering is not the right word, but like be aware of that, be aware that this all has to do with some kind of accountability at a very high, broad level across the whole state. So you're plugging in and being part of that ideally and showing some transformation. And if not, it's not going to last the same way. So yeah, okay, interesting to know some of those kind of guardrails in terms of when organizations are plugging in and saying like, okay, what's our part? Like, what are we implementing here?
Yes, and I think just a couple more things to know about where we are today with the Rural Health Transformation Program is that CMS is still issuing guidance to states on what they must comply with in order to be successful with the dollars that they were granted, that they were already awarded. Therefore, states are still trying to figure this out. And this is why we have had such a slow trickle out of RFPs for states because they're really still trying to figure out like how do we comply with all of the regulations that come along with this funding. So to date, I just looked at it this morning. We only have 4 states that have started to deploy requests for proposals and notice of funding opportunities. We have a lot that are in the pipes and will be coming down. Here in Arizona, we have the Office of Economic Opportunity Access, our state Medicaid plan, and then the Arizona Department of Health Services that will be really deploying these funds. And we have yet to see anything come out in our state. And I don't think that we're going to until later this month or maybe even a little bit more midsummer because, again, you've got access really still trying to figure out CMS's guidance. Same thing with the Office of Economic Opportunity. I just heard the leadership from these 3 departments speak last week at the Arizona Center for Rural Health Conference. And that's what they're all saying. We're still trying to figure this out. But that doesn't mean that organizations can't be preparing for these funds so that the minute that these grant opportunities come out, they are prepared to apply for them. So that's why I said, like, look at your patient population now. What problem can you solve? What baseline data can you pull? Be prepared. Don't wait for them to come out. Do the work now.
Well said. I want to double back on the partnerships side here and just see like what else is useful for a rural health center to think about partnerships. I think we talked about technology vendors already and kind of some of the state, for instance. Are there other types of partnerships that they should be thinking about to help as they implement initiatives here?
Yeah, I really think so. So you're right. Like technology vendors are I'm going to put it in quotes, air quotes, partnership, because they're really just going to provide you with the tool, the device, the platform, the data exchange availability, but they're not going to help you with your internal workflows to make those tools really work in the organization's best interest. You have hospitals. Hospitals are another great partnership because they can serve as hub partners for specialty access. So we already have a lot of like federally qualified health centers and rural health centers that are staffing their clinics with nurse practitioners, and they have a partnership with a larger healthcare system like a hospital that they can do those e-consults when they have somebody come in that is out with a problem that is outside of their scope of practice. They can do an e-consult, be told exactly how to manage and care for their patient, and that means that they can keep the patient local. And for me, when we talk about accessibility, keeping care local is at the heart of that. So please think about not only hospitals, but other more mature, robust, well-resourced healthcare systems in your area that can be a true partnership to you. You know, here in Arizona, we have, for example, Benson Hospital. It's a critical access hospital that has a really well-built out relationship with Tucson Medical Center to do things like their telecardiac rehab, for example. If you had to send somebody from Benson up to Tucson to do cardiac rehab, it becomes really cumbersome. If you have a cardiac issue, you are tired. So being able to keep your care local really is better for patient outcomes and just their mental and emotional health as well.
So let's look at where this can get us. Like let's look at what success can look like. You think 3 to 5 years ahead. Again, we're in the first year of this. It's a 5-year program. What do you hope success looks like as we get closer to that 5-year time frame? How does it actually transform rural health here locally, maybe in Arizona, but also in other states across the country? What does success look like here?
I think it looks like that's a two-part answer for me. And the first one is that people built systems and projects that actually met the needs of our patient population. Did we build something that patients needed, that they wanted, that they found useful, that produced really meaningful outcomes in their healthcare journey? If we don't hit the mark on that, I think we have failed. So that means that our healthcare organizations really need to be paying very close attention to patient feedback. And when you are getting feedback that tells you that you need to iterate and change what you're doing, follow that lead, please. I think the second success metric for me would be that what was built with these funds is sustainable past the 5 years. We can't just get it right for 5 years and then fail after that because none of it was built sustainably. We have no promise of this funding continuing past fiscal year 2030. So make sure that what you build is what the consumer needed and wanted, and make sure that it is sustainable.
Love that. Well, imagine what type of progress we can be talking about if we're anywhere close to that along the way, and what we can be seeing in terms of bringing healthcare not just closer, but I agree. I think on the technology infrastructure side, for instance, we can see a lot of progress. I think it's clearly a relatively new focus area as far as funding being available. So I can see that being a focus, and then thinking about what that ultimately can do for someone who has always just said like our only choice for care is to either do something virtually or travel a long way. You know, have even if that's, a few hours, couple hours, we're always talking about the impact of care not being available or accessible nearby. And so, yes, like all those things will apply. So I would guess we could see some progress there as well in terms of people seeking the care that they need, partially because now it's available more locally, like closer to home. That again, it's not that easy. There's a reason why we haven't gotten to that point before this. Like, this
Yes.
is not an easy thing. Transformation is a capital T. So it's going to be a concerted, sustained effort. But as we do that, I just see such value in the work that's being done. So, I'll try to offer encouragement in this space for those who are in the middle of any part of this, any kind of application. So, really appreciate the time, Carrie, and just being able to think through all of this. As we wrap up here, just I guess related to that, I'd love to hear just in a broader sense, is there one achievable thing that we can do by the end of 2026 to make rural healthcare more consumer centered?
I'm going to go back to really engaging the patient to help you design what you are building. That is something that you can do right now and have a really good idea of what your patient population needs. I really cannot stress that enough because I have been working with organizations who have brought in things like remote patient monitoring. They've built a telehealth access point in their local library, and it's not being used. And one of the reasons why it's not being used is because we didn't engage the patient to help us design it. So engage them. They will give you valuable information and insights to make you as an organization, as a provider, more successful. And to your point, that is something we can start now and achieve by the end of 2026. I will say too that you as an organization, if you're thinking about applying for this funding, but you're a little unsure of what it's going to look like, how it's going to impact you as an organization, wait for the first year of funding to be done so that you can learn lessons from others and then think about applying for the funding in year 2.
Great advice. Well, perfect. Thanks for giving us some time here. Thanks for everything you're doing to make healthcare more consumer centered. We're looking forward to the transformation that's happening here in this space and appreciate the time today.
Thank you, Jared.